Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by the award-winning quarterly journal AACN's Advanced Critical Care, with information available at www.aacn.org/advancedcc. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. This is Andrea Schmidt, one of AACN's Clinical Practice Specialists, and I'm joined by Dr. Vicki Good, AACN's Chief Clinical Officer.
Hello, everyone.
Vicki, today's episode is one that we've been so excited about, and that is the subject of AI again in nursing. So we're back at it, diving back into how AI is working in hospitals, but this time it's not from a developer's perspective. We're really talking with the change makers, nurses leading the charge in AI implementation and shaping how technology is truly supporting patient care. And whether that be from predicting risks or saving time, I think it's going to be really interesting to find out how, as these tools grow, we keep care personal and maintain that human connection in nursing.
So our guests today bring a unique blend of clinical expertise and global insight. They've worked in hospitals across the United States and have experienced international implementation of AI. They are here to share how AI is reshaping workflows, improving patient outcomes, and yes, even making nurses' lives a little easier.
So with that, let's welcome our guests. First up, we have Dr. Olena Svetlov, a nurse leader who's been instrumental in integrating AI tools into clinical decision-making. So Olena, will you please tell us a bit about yourself and what sparked your interest in AI?
Hi, everyone. Thank you so much for having me, Dr. Good, Andrea. It's really a pleasure of having us today. Thank you. I've been in clinical practice for, about 19 years. And life actually put us together with the AI technology. And being a clinical nurse specialist, one of my roles is to be on the edge of everything that's going on with technology and research and share it with nurses and making sure that life is easier for the nursing bedside. So that's what my sparkled interest, my profession.
And joining Olena is Dr. Fiona Winterbottom, a nurse leader who has worked on AI projects with key healthcare partners. She's passionate about bridging the gap between tech and bedside care. Fiona, please tell us a little bit about yourself.
Sure. I'm Fiona Winterbottom. I'm a clinical nurse specialist also, just like Olena. I've been practicing as a nurse for about 35 years. And so this is really exciting, a really exciting time to look at how we can really make nursing care easier and focus on more things where we actually interact with patients and less about documentation. So very excited to talk about that today.
Well, I'm very excited to learn more about this topic, and anything we can do to help nurses be more efficient and spend more time with the patients is a great topic. So, Olena, we're going to start with you. So for nurses who might not have a tech background, how would you explain like the basics of AI, things like a predictive model or an algorithm, in a way that maybe would make sense to them, new in the world of AI?
Yeah, absolutely. And then I like how you said it. It's predictive models. And I know it sounds a little complicated, but just like two maybe centuries ago, what's been happening in 1800s was a lot of like mechanical revolution and people talking about, oh, the new cars coming off and the electricity appeared. And people were like a little scared. They're like, how gonna, sell my horse for the car? And I don't understand how does it work. A lot of fear that time. So a century now back, here we are. And we have AI coming in and now knocking in pretty much in every single computer and telling us, hey, I'm here, I can assist you doing this and that. So way back in 1852, very important person appeared, Lord Byron's daughter. Her name is Ada Lovelace, she basically came up with a great idea as a mathematician. Hey, what about this statistical logic that can learn and empower the practice? And that was her idea, and nobody really talking about her. But I want to make sure everybody knows. So ever since, she empowered everybody else. So in 1950s, here our amazing engineers in the United States start talking about it, and across the world, hey, what can we do about it? So mathematicians basically come up with a logic model. And at Dartmouth University, John McCarthy, he was an assistant professor at the time. So he was the first one to put it out, the algorithm that actually can learn and repeat itself and come up some kind of a programming there. And ever since, 10 years after, more algorithm came in and more algorithm came in. And I'm like, well, that's too far from nursing. It's like nothing to do with nursing. And then only in 2017, where the first robot can appear, and we start talking about what can we do about it in our day-to-day basis, COVID came in. And that really boosted it out. Okay, we need assistance. And that's how the AI technology really get close to the medical world and specifically to nursing. And I know we're going to talk more about it. Really excited.
It's hard to believe that some of these concepts have been in place for over 100 years,
Yep.
and then just being brought to fruition. But I think it does put things in perspective when you talk about, the Industrial Revolution, the Mechanical Revolution, and all of these things, and the fear that people had. And I think this is exactly the same,
Yep.
except it just seems, at least to us, we didn't live back then, right? But much more fearful now, because I think there's this fear of things taking over the human, work, because it is such a logic driven thing, and it's in fact smarter than us in some ways. And I think that's where a lot of the fear comes from.
Yeah, that's true. And I hope by the end of this podcast, there will be no fear. We're going to give you some kind of a really great tool so you can empower our practice from day to day, not necessarily by the bedside, but basically in daily activities.
Fiona, I want to pull from your article from Critical Care Nurse, from reactive to proactive. You really wrote about how proactive rapid response models supported by early warning systems and AI can catch deterioration earlier. So how have you seen AI actually strengthen rapid response in practice, and what's being done to prevent things like alert fatigue?
Yeah, great question. So we adopted AI for clinical deterioration in 2017. It was a program that we started that was really kind of a gift that kept on giving, because we tried it and it wasn't perfect. So we had to figure out how to use it best. It worked by about 200 different data points within the medical record that pulled and triggered for early deterioration. And so initially, it triggered a lot of people we didn't want it to trigger on. So that was a learning. It was very early. So when we think about these models, you have to figure out, are they early? Are they late? What is the time periods? Because if you're thinking about that kind of alert, like a rapid response, it's not. It's very early. It's probably 24 hours early. And so at first, that was a bit frustrating for us because we thought the patient should be deteriorating. But what we learned was that if we intervene, so let's say we looked for somebody who maybe had sepsis and gave antibiotics earlier, or watched out for their blood pressure, and we found that we really did move things upstream. So it can't live in isolation. It had to live with a workflow. So we put the predictive model or the clinical deterioration AI with a proactive nursing rapid response team. And once you partner that with some early warning scores, which are also within our medical record, it really made it so that we were able to proactively, go seek out patients that were at risk and actually intervene earlier. And then we had that in about 2017. So about 2019, we started looking at wearable devices. And so the medical record is only as good as what's documented in it. So if there's not documentation, it's not going to be early. And we know that sometimes we lag, right, with vital signs or if we're getting busy. And so what we did with our wearables was we were able to have the data from those directly flow into our electronic medical record. So we could get vital signs like every 15 seconds to every 15 minutes, depending on however we prioritize the alerts, which is, usually vital signs are every 30, every 4 hours or 8 hours. So that continuous data feed helped make the alerts better. And then during COVID, we had lack of staffing, we had very sick people, we had to gown up to go into rooms. Well, we let the devices do our vital signs for us. And so that was huge in adoption because, you got to get people to trust the tools, right? So that was huge in adoption, really because people didn't have time or they were too scared to really go into rooms. So, and it also was much more comfortable for patients because they felt like somebody was still watching them, even though they didn't necessarily see a face. So I think, they're just things that we've learned over the last, 5 to 10 years that I think, gave us the groundwork for some of the other things that we've done.
Right. And I often say that I think one of the positive things that did come out of COVID is the fact that we adopted technology at a much more rapid rate because we were kind of forced to have to look at different ways to do things that normally clinicians aren't comfortable with.
Yeah, and I think the second piece of your question about the alarm fatigue, I think what we learned through COVID and since then is that it's very, we don't need to send every alert to every bedside nurse. If we send it to a specialty team, we can do that. So that was our, rapid response team or our proactive rounding nurse, or we used our virtual ICU. And that's the other people who can receive the alerts, who have a little bit more bandwidth, experience, and capability to really sweep through those when they're not being distracted by on-site things like call bells and, medication rounds and things like that. So, again, it's all in how you use the tools and putting a structured workflow around it so that it can be supportive, because we don't want alerts and alarms going off that nobody's looking at. So we need to make sure that we put those, that infrastructure in place. We did also in the middle of COVID initiated a sepsis alert program, and that sent thousands of alerts to the bedside. So that was another thing that we took on in our virtual ICU, and we started a sepsis program where we answered the alerts or triage the alerts so they didn't go to the bedside. So that was very rapidly adopted. Like in probably 2 weeks, we decreased the alarms by probably 70% that went to the bedside.
Wow.
That's awesome. It's too bad we can't do everything in nursing like that, right? That rapid turnaround. That would be great.
Yeah.
I actually have a follow-up question for you, and it's mostly for our listeners in case I don't work at organizations that are doing these things. And so I wanted to clarify for 2 points. You had mentioned that your model is working, it can work in conjunction with an early warning system. So I assume you mean something like a Muse score or something like that. Okay, just wanted to verify that and call that out. And then you said it can look at like 200 different things. Would a few of those perhaps be like lab results or other things like that? I was just trying to have them get a visual of what that might be.
Yeah, so that we actually have, we build patient lists within our medical record. We also have notifications that go through, electronic formats, whatever yours might be at your facility. So it can go directly to a nurse's phone or a provider's phone or through the electronic medical record. It goes either way. We have multiple different alerts. So it could be a Muse, Pews type, alert. We have a separate clinical deterioration alert. What we found is that Muse is very vital signs based. So that's very driven off if the vital signs are there or not and what they are, whatever's documented. So they tend to be the later kind of prompts, but the clinical deterioration AI has lots of things. It kind of triages through labs, notes, vitals, like it'll look at the differential on a CBC, like it looks in detail at things. Some things are more heavily weighted than others, but there's a lot of pieces and parts to it that are any data point really within the medical record. So it looks at trends, but it is very early. Like we don't see it late. We see all of that very early. So for example, the differential on a CBC, like you will see that very early. So yeah, you'll see the differential on a CBC change, right? Before you actually see a patient like have sepsis. You'll see things like that, or a hemoglobin drop before they actually maybe need a transfusion or have a GI bleed. So it's very predictive, especially the more data it has, it's much more predictive.
I think it's fabulous because in the end, obviously it prevents morbidity, mortality, decreases length of stay. I think it's great. So Olena, I have a question for you. So you shared before about AI and even robotics in nursing. And so what are you seeing right now in hospitals? And what might be coming in the near future that can support nurses, not take away, but support so that they can still have that human connection and really be at the bedside?
I love this question. That's really core of nursing and core of actually anybody who lives today, right? In today's year. Well, first of all, so what do we have around us? Well, I want to make sure our listeners understand there are like three types of AI, and sometimes we think they're not an AI, they're actually an AI, and that we know that for a long time. We have a narrow, weak AI. This is our digital voice assistants. We have a search engines like the one that you use, like Bing, Google, any search engine that we had for the past, 20, 25 years. So they've been with us for such a long time. And this is the model that we used, and it's considered to be like a weak AI and kind of like getting us ready to it. And the types of AI that we're familiar on a daily basis, we call it strong AI. So this is artificial intelligence algorithm that actually from producing can learn from what they produce to us. And this is algorithm that we use on a daily basis. So some of the people are using a daily basis. We hear about it a lot. It's like ChatGPT. You have Claude, you have Perplexity. And all of these models, they are artificial intelligence. They are strong AI. With the right prompting, they can actually produce the information. And with the production of this information, they can give you suggestions, give you ideas. But the key is not to take over. It's a tool. We should not be really fully relying on that. We should really double check what they're suggesting. And for example, my personal story is this summer I wrote an article with one of my colleagues and spent literally like a lot of time writing this article. And then one of my tasks at the end was to put it in the references. And I'm like, oh yeah, sure, no problem. I'm going to put the references in alphabetical order, whatever is needed. And I'm going to put it on the, ChatGPT. They're going to go alphabetize for me. And without proper prompting, I put it all in, we all to go, first peer review, pass, all good. I'm like all excited. Yay, my first article going to be published. Yay. And guess what? So on the second peer review, they check in the references, and my ChatGPT request hallucinated 2 more articles. So with no prompting, we're a failure. And it's so important for us that, yes, on your daily use, you can use those programs, but please use your common sense, go back, check, double check. So I was mortified, honestly. I was mortified, my first article by a first author, and just such a failure with the AI, but But I'm telling you today, please, please, please double check. It's a tool and it's a strong AI and we can use it. What we have in the hospital, so we see hospitals, I know in California, practice in California, larger major system adopting Epic just released, and I know Fiona, we were talking about it earlier, just released AI in the system. So help to solidify vital signs, put it out there, help with the note taking, keep it like open-ended, so the nursing and doctors can actually chart accurately. What else we have? We have actually actual robots. So something to share with you, and you probably heard about it. 2017, like Fiona was sharing that, sepsis model was developed in the Oshner system and others, right? Predictive models. Well, the robot Sophia was actually built by Hanson Robotics in Hong Kong and really skyrocketed this news. It came to different countries, visited actually US, and we're in a talk show and we're trying to talk to the robot. Oh my gosh, we can't believe it. The robot is talking, making jokes and having suggestions. So with that, went to Middle East and Saudi, became a first citizen of a global institute of humanity. And I was like, oh my gosh. And now having Robot Amica with United Kingdom engineers, and we have more and more ideas coming in, especially with COVID. We actually can protect nurses, creating a robot that can do the tasks. And this task will be in a highly, let's say, contagious environment where we can actually deploy the robot, a human-like appearance, with a human-like voice and operated by nurses, by us. This is something that Fiona just mentioned, telemedicine, virtual ICU, but at the same time, you have a robot there for the presence. So this is all happening right now. Daily basis, we have Moxie robot that's actually like populated about 30 hospitals in the United States adopting the model. It's actual robot with a face kind of like a very friendly appearance, and it's an assistant to clinical partners, to nurses, going from one place to the other, delivering medication, giving you hearts in their eyes when they see you, and saying thank you, with this little emojis. This is what we see, right? What we see on some hospitals in cafeterias, and actually in California cafeterias, I saw it as well in restaurants. So we have a tug, so special box coming in and delivering food. So we already have this small models of robotics available. And we have something bigger that we're talking about, and actually they have some talks in Congress and a closed door this year about super artificial intelligence. We call it the SAI. It's a machine that exceeds human abilities. So if any robot, any predictive model is written by the human with the algorithm, right? So we're putting the algorithm and it goes and it learns from the algorithm that the human developed. So super AI, it's actually artificial intelligence that supersedes what a human ability is. And, there's good things that people think about it, a cure for cancer, cure for, complete cure for HIV, complete cure for some kind of unknown viruses coming in. So, can kind of run through the multiple codes and realize what needs to be done, like in genetics or some kind of vaccine, come up with the idea about that. But at the same time, might help the US budget or anything like that with the health administrations and with a very challenging, nursing force that Fiona was mentioning. We need some very strong nursing force able to support our patients, so we're together. But at the same time, what about the existence of a human? Kind of like odd question, but what if like super intelligent think, humans creating a lot of garbage or waste? Maybe humans don't need to be there. So as a nurse, we really need to remember that my role to advocate for a patient, and if it's organization, but actually if we choose a profession as nursing, we're carrying on the global perspective for humanity. So that's why I'm really grateful for you inviting us today to discuss that, yes, AI is there. We need to own AI. We need to understand the AI and be at the table with those who are discussing and who needs to be there, making policies, procedures in the hospital, making legislature on a country level and on global level. So this is what we have today, and we need to be that strong voice for our patient early on before somebody will decide it for us.
So Fiona, I'm going to ask you to build a little bit on what Olena talked about, because I think she might have struck a little bit of a nerve with some of the people in our community, because I hear this all the time. The last thing I want is this robot to take over my work. And so, how do nurses keep in mind and balance the sense of using this as an adjunct to lighten their load, but this fear factor of this is going to take over my role?
Yeah, so I think it's a very scary time, right? It's exciting but scary. And I think a way to do that is to make sure that nurses are involved in the testing and the driving technology. So we have had lots of things that have been given to us as a this is a great idea, but maybe it's not so great, right? When you actually go to use it. So I'll give some examples, to follow on from what Olena was saying. Um, we we were given a robot. Oh, great, this robot's going to do something. Okay, well, where does it get plugged in? How does it move? Who's gonna check the batteries are, still okay? Like, who's doing all the jobs? So I think one of the things that we're trying to do is to put the technology in the hands of the nurses early so it can fail, but fail fast, right? Because
Mhm.
if the nurses don't test it or they don't like it, or it's more work than they were doing before, they're not going to adopt it. So you'll never get it to work. You'll never get it to really be embedded into practice. And so I think ensuring that they are part of the conversation early is critically important. And so to Elena's point, like our committees need to have people who are willing to test. So everybody knows if they give me something, I'm going to test it. I'm not really testing it. The nurses are testing it, but we're trying to create an environment where we can build trust. So if you give them a device that you're like, it's probably not going to work, but we'll test it, then you need to be ready to have another one that is better, that maybe they will like, because that way you'll build that kind of sense of testing and retrying that will build the trust in the end. Does that kind of answer the question a little bit?
Yeah, because I think the trust factor is a major concern right now is, one, how do we ethically use these platforms? And two, how do we preserve that role of the nurse? Because at the end of the day, a robot can't be the caring and compassionate person that we need at the bedside, because that's the true difference that a nurse brings to the equation.
Yeah, I think it's, just one of the things is how do you figure out who does what work, right? What level of person or device needs to do that work? So to Olena's point, we're using some summaries right now that I quite frankly think are fabulous, but it summarizes, I don't know, whatever, however many days the patient's been in the hospital, whether it's one or whether it's 30, and puts it into a like one-page summary document. It tells you what happened at admission, what happened throughout the course of the hospital stay, and what are the recent events. With that, though, as we test that, we have to make sure that it's valid, it's not hallucinating. And so the way that we're testing it allows people at source. So when I'm generating the summary and reading it, I can give
Mhm.
feedback immediately. Like I don't have to wait. I don't have to send an email. I am in the note that's generating and I press a button and I give it my feedback right then. Do I like it? Is it not medical enough? Does it have the wrong information in it? How did it get the information? The other thing that is in this particular summary that we're testing is it's a bit like having a reference or a bibliography. You can
Mhm.
click it so you know where it came from. So if I'm looking at it and I think it came from somebody's note that maybe they just copied forward, I
Mhm.
might not trust that. But if it came from a lab and it was actually from a lab or from a EKG or from a CT scan impression, okay, then I'm more likely to believe it. And so some of that is, I think we have, again, you have to put it in the hands of the people that do the work, let them have an easy way to give feedback in like in a large scale way. It can't be just a onesie twosie. It's got to be, everybody's got to be able to give the feedback, which is how you'll collect, the best path forward.
Well, I love that because I always question, especially back in my day of charting when I was doing paper flow sheets and stuff, there was so much redundancy in what we were doing. And it's like, this information's already in the chart, but I'm repeating it. So if the bot can do that for us, wow, what a great gift, because then I can spend more time with my patient where I want to be.
Well, and I mean, there's a lot of things now that are, going to be available. I mean, they're available now. They're just not always affordable and fully tested. But we have Vision AI that can see, that it can see things. We don't have to say, oh, the patient just left the room from the OR and is going to go to PACU. Like it can auto-generate that information to whomever might need it, the patient, family, the nurse, whoever it is. It can see things that we can't necessarily see because we're not in the room. There's so many use cases, and I think we're going to suffer from trying to look at which use case. I think that's going to be the bigger problem, is going to be trying to figure out what use case works for our organization, because what works for one may not work for somewhere else. But I live in Louisiana. We're 80% rural hospitals. This gives the ability for some of our hospitals to care for people like they were if they were in an academic center, in with great specialties. Like this provides that ability to diversify the care and allow everybody to get great care. And I think they're the things that we have to focus on.
I love that. I think that the documentation burden and the recognition of things, when somebody is not around, I think is great. I think where some of the chatter and the fear and things that I've heard, and even myself, to be honest, is the physical robot that may come into the room and help with tasks. I think that's scary because that's where it feels like, okay, so now what's going to happen to somebody's job? Or what about the elderly patient with dementia or somebody who's having a psychosis? What is that going, to do to them? And so these are things that I think about a lot, and I'm sure I'm not the only one, So I think we have a long way to go, is my suspicion, but I could be wrong.
Oh, 100%. And I think you have, again, it's about use cases. We have robots that deliver things. Okay, delivery is great. Please deliver the ice, the newspaper, the towels. I don't necessarily
Yeah,
need a person to do that. If I need
exactly.
somebody to hold a patient's hand and have a difficult conversation, okay, that's a person. Right.
Yeah.
So you have to differentiate with what is, what needs a human brain and what, or a human, and what can be done by a computer and triage, appropriately. I
Mhm.
don't think we're at a stage where we can't do without humans right now. I mean, maybe we'll get there, but I think there are things that are always going to need to be humans. I've been doing this for 35 years. There are things that we didn't have, right? We didn't have some of the documentation and the technology and things like that. Today, I can speak my assessment and it goes into the medical record. That's what I used to do 30 years ago. And then I got where I didn't do that because we had to type it. I wasn't born a typist. I didn't go to school for typing, but we've gone almost full circle from what we were doing, and then we got all of this other clutter, and then now we're getting back to oh, look, we can be nurses again. Look at that.
Awesome.
So let's shift a little bit from, the patient care aspects and let's talk about just our own self-professional development. So, Olena, how do you see tools like AI and VR and even, Chat GPT or Microsoft Copilot shaping the way that nurses train and stay competent and continue to grow in their practice?
Oh, absolutely. As a CNS, we're working collaboratively with the nurse professional development and educators, and we're developing those competencies. And in order to maintain their competencies, we got to have some kind of a tool that actually will tell us, okay, who is competent, what not. So in the past, we have one competency once a year, competency, and everyone has to go through. Like the nurse who's 30-year experience, like Fiona, 35, right? You're going to be so the same paper to the new grad and to people like Fiona and like me, right? So
Right.
that's how it is today. So what are we changing it right now? So with the help of the AI tool, especially, I use a Gemini and a Copilot. Copilot's kind of like easy, slow motion, but kind of like gives you an idea. Tailor the competency based on the experience. So and that would be ideal if, like in just the near future, we can develop a model that I will have my new nurses not to be scared with the open heart admission, tandem heart, VA, ECMO, and all of that at the same time, putting on them. Rather, I would give it or partner that nurse who is with more experience, and the competency is evaluated based on the experiences that the nurse actually has. So the co-pilot kind of gives you the idea how you model that and how can you come
Right.
up with the ideas. And sometimes it actually takes over. It's like, hey, would you like me to develop the whole competency paper for you? And you're like, wait a second, okay, let me try. Right?
Yeah.
We go in, we click try, and you're like, wow, that's a great idea. So let me just modify it with adult learning theory. That's something that Copilot didn't even think about it. And I go back and I'm like, hey, let me actually implement this checklist, but with a done the right approach. So, which is like evidence of daily work. So if I have a nurse who, new grad, but constantly, like once, 3 shifts, every shift that comes in and they have a pacemaker, well, I expect in 3-4 months, this nurse is going to be fabulous, right? With the pacemakers. So I'll develop this checklist based with a Copilot model that can help me with this. And then with the VR modality, this is really huge. This is like a dream to come true. If I ever had a grant, if I ever had some kind of money coming to my pocket, I will definitely invest into the VR and a high fidelity simulation. There are a bunch of literature out there, evidence-based out there, that every human being coming in and immerse in the simulation environment can train those skills away from the bedside, away of being afraid that I'm going to harm my patients or I'm going to make a mistake. I'm actually going to live through this experience, and I'll be able to practice this to the point that I'll be excellent in delivering this by the bedside. So VR is, the way to go, except one thing, it doesn't really give us an opportunity to feel like sensing the object that we go, but there are companies out there, and I know there are high academic institutions with some generosity funds. They have those platforms where nurses are able to practice, hand hygiene, practice wound care, practice rapid sequence intubation. So you cannot really simulate it on a low fidelity mannequin, but with VR and a high fidelity mannequin, so you can feel it. You can feel the operation of the instruments. You can see the ventilator. You can see what the settings are. You can, check for sedation on the patient and assess and see how so basically you can build it through the VR experiences. So that's, if any of the fundraisers people are listening to this podcast, please help nursing to live through this, because we can actually empower our nurses and our future and basically make our patients better and recover faster. Andrea earlier brought it up for geriatric patients. It is a scary experience. Delirium is not, it's not a joke. We experience delirium when we fly from one country to the other and we're waking up in a different area. We're waking up, it's like, okay, hold on, where am I at again? Right, Fiona? We've been traveling for some time. And that's a moment of delirium where we're able to actually get ourselves out there based on our chemicals, metabolism, wellness. But our older patients coming into unfamiliar environment, they cannot get out of it. So that's having nurses train in simulation environments through the VR system and algorithm and the AI will help us to get them ready, and our patients will get it better.
Yeah, I think the AI, VR with the AI is phenomenal. It's taken simulation to a whole new level because you can interview a patient and it
Mhm.
talks back. It learns what you say. I've actually seen people lean on a desk they think is there in the VR and fall
Mhm.
because it's so realistic. You can feel pulses, like it's gotten that good where you can,
Wow.
check a pulse. And I had one of the mannequins tell me, "What are you doing?" And I said, "Oh, I'm checking your pulse." "Well, is it okay?" And so, I mean, very intuitive. So I think there's a lot of different practical abilities there, something that would have been great if we'd have had it in COVID, right? For a lot of our
Mhm.
nurses that had to train in sim centers, it gives you the ability to see every type of patient, not just because you came across them in your training with experiential learning. So it's a different type of experiential learning. Um, and it can significantly expedite your ability to orient and precept staff, whether they're physicians, nurses, whoever it is, to really get those skills much more quickly. And so they're the ones that have multiple modalities are the most helpful. So it could be, a headset, it could be done on a computer, it could be done on a laptop, phone, whatever it is.
Yeah.
And it gives you different ways to interact with the program. And then there are some really cool ones out there that teach soft skills. How difficult is it to teach
Mhm.
soft skills?
Right.
That can you
Mhm.
can so I take S-bar as an example, right? So we try
Mhm.
and teach S-bar, but it's all a bit theoretical and doesn't really flow very well. So
Mhm.
they can basically you can have a conversation with somebody, let's say you're doing ACLS. You can do that, and then they will let you know if you were the leader, if you were not like if you took the correct role that you said you were taking within the program and score you, but it's not Fiona or Elena scoring somebody, it's a computer, so it's less
Mhm.
threatening to the learner. So there's all these modalities that are out there that are tools I wish I would have had when I was a new nurse,
Right.
like
Right.
phenomenal.
Yeah.
Well, and I just think about how it would be great to have that orientation plan that's customized to me,
Mhm.
and not to everyone. So,
Mhm.
Correct.
and then I've heard, some of the hospitals are now starting to look at annual competencies, and they can go and evaluate the patients you've taken care of in the EMR and say, these are the competencies that you need to be checked off on next year because you haven't had as much experience with these skills
Yep.
than you know, over the
Yep.
past year. So I see so many opportunities.
Yeah, and
Yep.
it's so exciting times, and then having these high fidelity mannequins and having us helping and shaping the future of nursing competency. It's just tell us how, on the global perspective, we're getting ready for the future, and the future is today.
I know we're running close to the end here, but I do have one question, Fiona, for you. I want to circle back for a moment, because you touched on it earlier, and that was how, as information is being pulled in, it creates these summaries, right? But you said that you need to verify the accuracy. Okay. So, as we know, novice to expert, right? So, you have 35 years of experience. I have 33. Vicky is about the same. We probably could easily find those errors. What about the novice? How are they going to know? Because what they don't know what they don't know. So how are they going to, spot it, or are they just going to quickly read it and go, yeah, it looks good, and people get click happy, right? Or whatever this model looks like. What's the training for that? How do you
So I
guarantee?
think Yeah, I think that's a great question. So I think you have to, again, this is putting it in the hands of the right people to test it, right? So I don't expect that what I'm testing today in pilot phase is what we will deploy to all of our frontline staff. We're going to test it and we're going to make sure that it's not making errors, and we're going to give all of our feedback with some selective staff from different disciplines, different age groups, I say experience levels. We're going to try and have everybody give input. So we started with a small group of providers. So I'm a clinical nurse specialist. I do doctor work and nurse work. So I can kind of triage a little bit of both. We're having our pharmacists test it, our physical therapists, our case managers, because everything is a different use case. And again, you put it in the hands of people will look at it, test it, and then you've road tested it, right? Just like you go and buy a new car, you're trying to do that and give it the feedback along the way to be able to make sure that when you do make it available for prime time, it's a good product. That's kind of where I think we have to use our experience and our knowledge.
Yes.
Our virtual ICU teams, everyone's 10 years or above experience. They're testing it for us. Our rapid response team, they're testing it. They've all got 5 to 10 years of experience, like trying to make sure that if it hallucinates, we're catching where it does. And I can tell you where it's doing it right now. Note templates that pull in the wrong information. That is what it's things that are copied forward or pulled in historically. And it's actually learned, I think, since we started in like maybe July looking at this. It's already figured out how to put in things, take out things, like with the feedback that's already been provided. So, again, you can't just throw something out there and hope it's going to work, because it won't. You really have to work the problem. But if we don't work the problem, we won't have good products. So it's kind of, you've kind of got to do a little bit of, okay, we're going to test it. It's, what is it? Enemies, the perfection of, I can never remember that saying, but perfection is the enemy of good, or something like that.
Yes.
It's not going to be perfect. So just road test it, figure out what the problems are, and then mitigate them before you give it to everyone.
So I think we could talk about this for many, many hours, but we need to bring this to a conclusion. So as we draw to a conclusion, I would love it if each of you would give our listeners one takeaway. So just a simple sentence takeaway about how they should start to look at engaging with AI in their own practice.
Fiona?
I would say embrace the change, be part of the journey, and you will help us move faster and further than we have in any decade thus far.
Wow. That's pretty good. Olena?
And I would say that think global, attend different conferences. Don't think just about the United States. Be curious what's happening around the world. For example, I was in an Emeritus critical care conference, and that's like a fairy tale that I saw, the technology out there, and connect with the leaders that you see in the different areas that you are, so you can actually make a difference and you have a voice, and be open, and remember, it's only a tool.
I like that.
Well, this has really been so fascinating. It's so interesting. And I agree with Vicki. We could go on for hours about this. But I will say that I think today's conversation has really showed us that AI can strengthen nursing practice. And it's going to work best when nurses are involved in shaping how the tools are designed and used. And Olena and Fiona, your insights are so thought-provoking, and they really make me wonder where we're going to be in 3 years, let alone 10, right? So thank you both for sharing your time, your wisdom, and your experience with us today.
Thank you so much for having us. Such a huge honor.
Thank you.
You're both very welcome. And thank you to all our listeners for joining us for today's episode. As always, we welcome feedback on this episode as well as ideas for future episodes. Please send your feedback to podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's award-winning quarterly journal, AACN's Advanced Critical Care, with information available at www.aacn.org/advancedcc.